So, what are group clinics? Let's all make sure we're on the same page. So, group clinics are an alternative way to offer planned clinical appointments for people with similar clinical problems, and their carers or chaperones can attend alongside them if they wish. Group clinics include a group discussion as a primary part of the session, and that group discussion includes the patient's common concerns and what matters to them. And then, as another key part of the session, it includes the individual one-to-one reviews, clinical assessments, discussions of biometrics and treatments, and often prescribing as well. So we have that group section and the one-to-one section where the other patients listen and observe. Group clinics, if you're doing a VGC, which is also known as a video group clinic, they usually involve around 6 to 8 patients. And if you're running a face-to-face group clinic, you can allow a few more, so around 10 to 12. Group clinics are always managed from start to finish by a facilitator. They play a really key role in group clinic delivery. And they are typically around 60 to 90 minutes long, with the clinician present for that central clinical session, which lasts for around 30 to 45 minutes. And if you are running a VGC, a video group clinic, they need to be conducted via an NHS-approved video platform, such as Microsoft Teams. Okay. So just to spend a bit of time focusing on group education and group clinics, we often find that we need to clarify the difference between these two different types of group care. So group education will usually have a preset curriculum, there may be a lesson plan, and it's usually run by a clinician educator who is accredited and often assessed to assure the quality of their education. And there will be perhaps a participatory group discussion, but this will run alongside their routine planned care. So a key point here is that there is not a one-to-one discussion, and it's not described or classified as a clinical appointment. So an example of that type of group education in primary care would be something like the Desmond course for diabetes. Or in specialist care, it might be something like a pain management course to support people with chronic pain. So in terms of group clinics, so these are much more structured around a specific clinical assessment or a review. So an example of this is an annual diabetes review or an annual asthma review. So they are really led by the patients and their questions and concerns. And it's really person-centered care. So the patient is at the centre of that group clinic. It includes that participatory group discussion that I talked about earlier, and that personalised one-to-one discussion where the other patients listen, observe, learn, and understand from listening to others one-to-ones. Okay, and a group clinic does usually replace a clinical appointment, and it can be classified as a clinical appointment. Okay. So there are 3 core roles involved in the delivery of a group clinic. You have your clinician, the facilitator, and the group clinic coordinator, and each one plays a really key role. So the clinician, of course, is the clinical expert. They deliver the central part of the session. They answer the patient's questions, carrying out any clinical assessments, and they make medication changes potentially, and they'll be providing guidance based on their expertise. The facilitator works alongside the clinician during that live session. They're responsible for setting it up, completing any location identity checks, and generally making sure that that session runs really nicely and smoothly. And then you have the clinic coordinator, who is a bit more behind the scenes. They might not be involved in the delivery of the live group clinic, but they make sure all the logistics are in place. So they invite the patients, send out the patient agreement, any pre-clinic communications, they'll book time in the clinician's diaries, etc. So when all 3 of those roles are really well defined, a group clinic will run really smoothly. So just very briefly, just to touch on where group clinics fit into your patient care pathways. Group clinics work well for what Chris Jensen describes as simple care. And by that, we mean that it is planned, it's routine, it's driven by guidelines and protocols, and there's often a bit of a self-management element involved as well. So in general practice, most of QOF fits within that category. So within that triangle there, you can see it fits in the middle within that simple bracket. And there are some risks that we need to think about around group clinics, and that's covered in a lot of detail in our training programme. So we need to think about things like third-party disclosure, confidentiality. We need to think about informed consent to share medical records. We need to also do an identity check if you're doing VGCs, just to confirm the patient is the same one who signed up. So we have a really clear 3-step process as part of our training plan to cover all of that off, which is approved by NHS England. And there's just a note there to say that the flow of a group clinic is the same regardless of whether it's face-to-face or online. So there's an example of a session flow there. So we had a go at this at the beginning of the session today to set up the masterclass, but you can use the session flows within your group clinics too. So a rough guideline would be to start with welcome and introductions, look at the patient results, gather the questions from the patients for the clinician, run the group clinic with the clinician, have some reflection and goal setting where you'll also do the one-to-ones, and then feedback for the team, and always pop your finish time on that session flow. In terms of how you can display the patient results, you can use a results board. So there's an example here from one of the teams that we've been working with who ran a diabetes group clinic. So you can see at the top there, you've got the patient's names all down this side. You've got their BMI, HbA1c, blood pressure, etc., etc., etc. So you can customize these to whichever pathway and topic you choose and what you feel is appropriate to be measuring for your group clinics and what's appropriate for your patients. You can also use a topic board to help structure and guide your group clinics too, to help you with getting your patient questions ready. And you can also use or alternatively, you could use a combined results and topic board. So on this side, we have all of the results that you could use as a template and input. And then on the right side there, we have some topics. So this one would be for a chronic pain related group clinic. Okay, so that's your setup and your introduction to group clinics. So we're going to hear from Laura now, who, as I said, is a nurse manager from Moatfield Surgery in Sussex, and she's going to talk about her experiences in setting up group clinics in her area. So I'm going to welcome Laura now. I believe her microphone might be muted, so I'm just going to unmute it and welcome
Hi, can
Laura.
everyone hear me? Can you hear me?
I can, Laura. Perfect.
Fabulous. Hello, everyone.
Over to you.
Thank you. Alicia, will you keep me to time if I overrun?
Of course, yeah,
Thanks.
I will do.
So next slide. So I'm a nurse practitioner. I work in primary care in Sussex, and I've been involved in groups since 2018. Next slide, please. So there's quite a few of us that run groups now. So I started initially, and I was the only one probably doing them for a couple of years. And I'll show you our timeline in a minute. But we include people from ours roles now as well. So we've got a pharmacist, we've got a myself as a nurse practitioner, a paramedic, we've got a GP who runs menopause groups, and we're looking at expanding it further all the time. So it's quite a wide team. Lots of different roles can run a group. So next slide, thanks. So where did we start? I think the hard thing is actually getting started. I noticed there were a couple of comments about people that have done the training, but it's just about getting going now. And I think that's getting off the ground can often be the difficulty. So our now senior partner met Georgina way back in 2018 and heard about groups. He works with an APC, so he'd heard about groups being used a lot in America and elsewhere, and could see all the benefits for it. I was enthusiastic in the idea of trying a different way of working, and we had our training. So we had myself, senior partner, our practice manager, and our patient services manager or receptionist manager all involved. And I think when you're trying to get it off the ground, you need a core group of people who are really interested in this new change and how it's going to go. So you've got your leaders, and then anyone that's interested, bring them along in with it as well. So you've got the people that are really energetic about getting this off the ground. There will be some people that are skeptical. There's always some people that just want to watch and see how it goes. They might be quite passive initially, but as they see how things can improve and how there's benefits to everyone, they can be swept up with it. There's often a couple of people who just find lots of reasons why this shouldn't work. As long as they're not in your core management team, you should still be able to go along with this. And there might be some people that really just need that reassurance that they could do this well and want to see how it goes a little bit. So I'd say for anyone that's ready to get going, get your core team and get them involved first of all. So we did our training and we followed the ELC plan to the letter. We just thought the work's been done for us, let's lift it and go with it. We did all the documentation, everything. And we set our first date for I think it was about three weeks after the training, really fresh. And to really stress ourselves out, we set up some further dates as well for the following sort of 4 or 5 weeks. So we knew this has got to work. We've really got to make it work. So we did our first diabetic clinic. It was fabulous. It went really well. It was really well received. We didn't cherry pick our patients. I think sometimes when you're looking at what group, what condition you want to look at, there might be some things to exclude. So in our first diabetic clinic, we excluded anyone already on insulin. We thought, let's make life easier on ourselves. It did overrun, but we used the improvement planner to look at it. But I think, again, if you're planning your first session, we gave ourselves the entire morning. So we had lots of time to prep, lots of time to catch up together right at the beginning, just make sure everyone was okay, we'd addressed everyone's concerns. Afterwards, we had lots of time to write up, to reflect on how it had gone, but actually to celebrate. That's it, we've done it, we've done our first one. We can keep this going now. So you do need a team behind you that are going to give you the space to make the first one work, because you don't want it to be a stressful thing. You want to go into it knowing you can improve things. They went so well that in January 2022, we started a second group because the numbers of people with diabetes is expanding so much. We then went on to train up someone else. Hypertension groups launched. They're really successful and you can get a lot done in a short amount of time with those. We started our COPD groups in 23. We made some mistakes with that. We made some assumptions about how to do it. So we thought it would work the same as diabetes and hypertension. But again, we've learned from it using our session and improvement planners. We've really looked at what works. So we're actually now building a room on the ground floor because a lot of patients couldn't get upstairs. We tried doing it off site. We used letters. So it doesn't, sometimes there are things that don't quite work, but you can see in the long term, it's going to be great. So tweak it. We now do new type 2 groups. So this morning I did a group for people newly diagnosed with type 2 diabetes. And the fantastic thing there is that's what they know. So their first experience of a review is in a group. And I saw 9 people and I was up there for an hour. Whereas for anyone that does diabetes, you know that a new person with type 2 diabetes can take 40 minutes or so. And there's a lot to cover. So it went really well. Lots of questions answered, lots of stresses and things covered. We've got our menopause groups. We're launching our asthma group soon. And now we've got a whole team of facilitators as well to really get things going. Next slide, please. Thank you. So as you can see, one of the big problems we had, and it's problems that other people might face, is where to hold your group. Ours is a meeting room upstairs, so it's excluding people with wheelchairs, accessibility. Our COPD patients really need some time to sit down and catch their breath by the time they've got up there. So we've actually managed to get funding, and this was our room about 2 months ago. We're hoping to start using our new room in end of this month, actually. So we're getting it all set up with a new room, and to open up the accessibility to really expand groups to the point that in the long term, we want to be running about 8 groups a week for different varieties of problem and condition and discussion. Next slide, please. So why is it good? So there's 2 things. I think about access and think about the workforce. So we're trying to help our patients, but we've got to think about ourselves as well. It's not the right thing for everyone. So you're not necessarily going to get 100% of your patients going to a group. So these were our figures for last year. Of 913 patients on our type 2 register, 470 were seen in a group. That's a half our population group. Now, some of our patients got complex care. They might be seen for triple review with heart failure and hypertension and asthma, COPD. So they're not appropriate to go in there. You've got your frail patients, your learning disabilities. So some patients aren't it's not the right format for them. So it's looking at where your quick wins are time saving wise. And as I say this morning, I would never have got through all those new type 2 diabetics all in a one-to-one back-to-back this morning. So it's really saved a lot of time. I said our hypertension groups, they have been really, really successful. We now run 2 a week. Also, though, you can find sometimes towards the end of the QOF year, you don't necessarily need those 2 groups. So you can condense it down into 1 group a week and use your staff skills elsewhere. COPD, we're really working on that. We're constantly tweaking that, but we still got 46% of people seen with COPD in groups. Really big wins when they do turn up, when we've got it right and we've really improved this. Things like smoking cessation, you as a clinician, you don't need to do the work. You just sit back, find a few people who have already given up smoking and they do the work for you. They're far more convincing with the rest of the patients about how to give up smoking. So that when we got it right, so as I say, we've improved it and we start again in July because we're trying to get everyone seen before the winter. They're really effective, and they're the group that people really like to discuss and chat with each other. They're far more chatty group. I've mentioned the new type 2 group, and we're looking at now, is there a role for pre-diabetes in groups again? So we're looking at patient groups where there's big numbers. Our menopause group, again, initially we didn't quite get that right. The timing was wrong. So we've changed the timing of it now and our numbers are much better as well. Next slide, please. But this isn't all just about patients. I think we have to think about ourselves. Our diabetes list has doubled here. There's no way we could get through everyone one-to-one. Our quality of care, our quality of delivery would lapse by the end. So we're saving about 2 hours of clinical time per group. Now, initially, when you're setting up, give yourself that time to really make a success of it, to problem solve effectively, to bring along the people that are really enthusiastic, but the people that are a bit skeptical or just need a little bit more time to understand how it's going to work, they need the time. If you're going to be thinking this is going to be perfect right at the start and you need to make time savings straight away, it's not going to work. It's really cut down the repetitiveness of our work, and we work in partnership with patients rather than them expecting us to do everything for them. It's really a case of, well, what do you think? What works? Share your skills. So it's really changed our working life. It's our first port of appointment for patients. So the whole practice understand this is our behaviour, this is the way we look after people, and one-to-ones are the second option. Alicia, am I running out of time?
You're fine, Laura, don't worry.
Okay, all I would say is just quickly to add on to that, it does work, but think about who the best people are to run it. Use the templates that are supplied by ELC, because you can then evolve it using your session improvement planners. You can evolve things over time. We've changed the headings on a lot of our tables and such. Use the car park really well and work with your facilitator. You need to be in partnership. So they're helping you, they're guiding you, a bit like me time checking then. They'll keep you to time, they'll stop you overrunning. You leave the end of the day feeling more positive. You've had some really interesting discussions. Your patients are hopefully getting better care, and you've covered all the cost stuff that you were trying to achieve in a much more meaningful way. I'm hoping I've covered everything.
I think you have. You've painted the picture really well, Laura. I've heard your work a couple of times now, but every time I hear it, I think, wow, what an impact you've had in your area, and how fantastic that, you know, your GP surgery is building a room for group clinics. You know, that's just incredible. It's testament to all the work that has gone on in your area. Fantastic. All right. So, over to Georgina then to help us understand a bit better about how to get going well with group clinics. Georgina, over to you.
Thanks. And Laura, can I just ask you a little question, which I already know the answer to? If your practice said to you, you've got to stop doing group clinics now, we've decided they're no good, what would you do?
I couldn't do it. I couldn't see that many people back to back, one after the other. No, I wouldn't want to walk, but I would have to, I think.
Never let that happen. So
No.
and that's the thing, isn't it? Because, you know, hopefully what we've got on the call today is lots of people who are, you know, really so much earlier on in the journey, and there's something about just people keeping that ambition in mind, isn't there, and that end goal, and knowing that, you know, when we're making change, things do take more time. It is difficult, but in the end, you'll never want to go back.
Absolutely. And I think some of our clinicians don't like public speaking. You know, they wouldn't be the person doing a presentation. And
Yeah.
but by watching it just going along, giving them the time, they absolutely love it as well. So they're quite happy doing that, and being really honest with patients. If you don't know the answer, you just say you don't know the answer, and you'll get back to them, which is what you do in a one-to-one. So I think it's a real partnership. But no, I wouldn't go back to just one-to-ones.
So and I think it's really important to recognize that, you know, you're not really doing a presentation, are you? You're actually, you know, it's not like a group education session. It's a conversation with patients as well. So I'm going to ask you, Rose has written a little question in the chat about your menopause group sessions, if you wouldn't mind picking that up with her whilst I'm just doing a couple of little introductory slides. So
Yeah.
I'm guessing that I'm hopefully got control of the slides now, Alicia, potentially. If not, then let's move it forward. So we first of all want to just check in with you as a sort of group of people that we're working with today. Pick an A, B, C, or D, and if you pick D, tell us what is going on for you right now. So what's the best way to describe where you are? I'm keen, but others are skeptical. That would be an A. We all want to progress, but we can't access funded training. That will be a B. We're all interested, but other issues just are more urgent right now. Or D, there's something else going on. So just pop, if it's a D, give us a little bit of an idea. We ask this so that we can make sure that what we are sharing with you is really helpful. So Ellis, do let us know what your D stands for. You know, what is going on. Give us a little bit more detail. Okay, cool. So we've got quite a few people who are in the sort of skeptical kind of category, with quite a few A's there. We've also got quite a few B's as well. So we will tell you a little bit about training later, and the invitation from myself and Alicia is anyone who wants to help get the business case made for training, we are here to help you. Okay, so let's move on. So just very quickly, I think you've heard Laura mention most of these things in her presentation. There are very, very well established critical success factors for getting going with group clinics. Strong practice leadership and getting the whole team to buy in is key. You heard Laura talking about that. Having an effective plan, being organized and being clear on why you're doing this is also really important. Think about what Laura said about how she really would never go back now to doing one-to-ones. That's why you're doing this. It's so that you transform your work life, transform your patients' care and support that you're able to give them, and that will keep you going on the darker days when it feels like so much work. Making sure you've got the right space. You might want to do face-to-face group clinics, but maybe your premises mean that that's really challenging. So maybe think about starting with video group clinics. It can work really well for particular groups, like, for instance, women who are dealing with the menopause, children and young people who might not engage very much with things like asthma reviews when you try to do them face to face. All sorts of different groups can actually find video even better. Making sure you've got a simple invitation process and compelling story for patients. So we've done a lot of work on this. We proactively work with people who really understand System 1 and EMIS and other computer systems. We can give you loads of shortcuts in our training pack and our route map to group clinics. And that is not for when people have got access to those resources. That is not necessarily such a big issue as it used to be. You also need to have a group clinic model that is addressing your workload priorities. We're going to talk a lot more about that later in relation to making group clinics pay. And it really helps to have training, because this is quite a big step, and so that you can build those facilitation skills and have a sort of framework. It's a bit like, for those of you who are clinicians, if you think about when you first did your first clinical appointments and you had to learn how to work with a patient and do a review, basically you're kind of learning a new framework, a new way of working with your patients, where you do clinical work in a group. So you need that framework, and that's what's covered in the training. Next slide. So what we'd like to know is from you, this is very much the way a group clinic would work, by the way, a video group clinic, is what are the questions that you have? And this is a topic board. Alicia showed you earlier a topic board, which can be used in a group clinic. What are your questions? When you look at these headings, what are the questions that are triggered for you that you would like us to talk about today in this session? So just pop any questions that looking at this triggers, and then we're going to go into each of these things and explain a little bit more. But if you've got specific questions that this topic board triggers, share those with us in the chat now. Okay, so Karen, how do you get everybody on board? So I'm going to let Alicia deal with your question, Anu, about observing a menopause group clinic, and tell you a little bit about our training and how we've got simulation training as part of that. Right, Sarah, when you say getting started, what do you mean by that? Maybe give us a little bit more, a bit more detail. What specifically? Okay. Brilliant. Okay, thanks everybody. Just keep those questions going. So creating headspace for this is coming through as quite a strong one by the looks of it. I know there's not a lot of headspace in general practice right now, so we do really appreciate that. Right, yeah, the session is being taped, so you will get a copy of it, the full session, afterwards. So if we could just move the slides on, please. So there are 5 enablers to getting going with group clinics, and we're going to work through these with you now. So how this is going to work is I'm going to share some details around this, and then I'm going to ask Laura to come in and add in any insights, further insights from her perspective, Laura. So we're doing that little tag team approach here that we know so well. So the first thing is, if you've got skeptical colleagues, often what they will say to you is, oh, well, what's the evidence for this? Okay. And it's really important that if you're interested in this, that you can talk a little bit about the evidence. It's going to be one of the ways of getting kind of senior partners or senior clinicians in your team on board. And as we know, as we heard from Laura's experience, getting those senior clinicians behind you is definitely a massive enabler. So the thing is that with group clinics, there are 15 systematic reviews. For those of you who understand and the different types of evidence, a systematic review is the sort of gold standard, gold star evidence. You can't get better than having a systematic review. And there are 15 of them. I'm laughing slightly because there's no other innovation that exists that the NHS has yet to implement at scale that has 15 systematic reviews backing it up. And that means that there is, a really strong evidence base. And the strongest evidence base is in type 2 diabetes. Okay, so Laura, that was where you started, wasn't it? Well, do you think it was partly because of the evidence base that you guys started with diabetes?
Now, I have to be honest, we just knew that there was lots of case stories that it worked, but also our numbers of newly diagnosed patients were going through the roof, and the waiting list were going up, and I couldn't see them quick enough. And it was really basic information like that. I'm sure our senior partner had looked through the evidence previously, but I'm afraid I didn't, but he knew that there was I think there was a lot of discussion going on around the country, and it had been done a lot, I think, in America, if I'm right, Georgina. So yeah, he was convinced, and I went with it because what I was doing currently was I was struggling.
I mean, to be fair, when I had quite a few meetings with Minesh, and I helped him put together the business case for training for you guys. So, that's the offer that's on the table for people who have got who want to access training. That it was a little bit of a partnership as well, but you're right, he heard it through his networks, didn't he? So the other thing is that the research also shows that it has a positive impact on staff and patient satisfaction, that quality of care is sustained, and we can give you the evidence for all of these things, that you'll have productivity gains, reduce waiting times, and free up appointments for patients who are more needy. And we actually, I want to put into the car park that we will send out to all of you a copy of a little slide set that is an evidence summary that you can use with those skeptical colleagues. So if you could car park that for me, Alicia, please. So there is lots of evidence, and you need to be on top of it. You need to understand that evidence and how to use it. Next slide. So the next thing is about making the case for funding. So one of the things that I would say to you is that if people say it's not a priority, it's because they haven't understood that this can actually help you to deliver your targets or your must-do things. Would you agree on that, Laura?
Yeah, I've heard of some teams using their extended hours for groups, particularly in menopause. Our GP doesn't, but I've heard that a few places, and it works. So you can use it quite imaginatively like that. We are looking at maybe doing a couple of groups on a Saturday for people that work every day. So using your extended hours, getting those targets, it works that way.
Absolutely. So these, I know that I've noticed that there are some people on the call who are working in other settings other than primary care. I think what you guys need to focus on if you're working in specialist services is waiting lists, waiting lists, waiting lists. If you want to talk to us about how group clinics could help address waiting lists in your service, pop your name into the chat and let me know the pathways that you're dealing with, and we will pick up with you and arrange to sort of pick that up with you separately. But for those of you who are working in primary care, what you need to be looking at this year, actually in 2025, is, as you said, Laura, enhanced access. So if you're within the enhanced access service, you get paid per appointment that you offer, not per appointment that you complete. And that what that means is that the group clinic model becomes very attractive, because in a face-to-face group clinic, you will be offering 10 to 12 appointments. So you'll get paid for doing 10 to 12 appointments in a 90-minute slot. So that means you get paid whether or not the patients actually come. So that can be really helpful when you're first set up to because if small numbers of patients come, it doesn't matter, you're getting paid for the 12 appointments that you would have if everybody had turned up, which is quite a nice thing to know, Laura. Might be a good reason for you to go ahead with that enhanced access model.
Well, absolutely. And today I had someone who didn't turn up, and it made no difference. If they'd been a newly diagnosed, they weren't particularly well controlled. I might have
Yeah.
considered, did they need 30 or 40 minutes, especially if someone's got any sort of enhanced needs. By them not turning up, it made no difference, because I managed to do everyone else's care instead of having that unbooked appointment. So that would really help.
Yeah, absolutely. So that's a really big thing for you to this is a really good hook in primary care. The second thing is QOF. Okay, so QOF, you've heard from Laura. This works, I mean, what's the right word, adjective, beautifully for delivering QOF. I think that's probably not an underestimate, because it's protocol driven, as Alicia explained to you. Those of you who deliver QOF in primary care, I mean, I am absolutely certain that you find yourself repeating yourself all the time when you're doing QOF reviews. So group clinics is going to make your QOF delivery highly productive. So we are just after April now in June, and that's one of the reasons why we've done this masterclass at this point in the year. And so that what that means is that you will know where you did well on QOF, and you will know where you maybe fell a bit short on QOF, and you'll know the bits where you ended up sort of chasing your tail in the last quarter of the year. So get a plan together and share with your clinicians and your practice manager. If we do group clinics, it can help us deliver QOF more effectively. That's a really important one. Okay, so and the toolkit that we have as part of our group clinic training and route map covers over 60% of QOF with tried and tested group clinic models. So it's really, really comprehensive and can help you to really accelerate your progress. The next thing that I want to mention is something that is called QuizMet accreditation. And this is something that I've just recently talked to Laura about. And in fact, Laura, I can update you a little bit on this, because I'm just in the process of writing a little resource on it. So in QOF this year, you can get 11 QOF points, which is equivalent to about £2,400, something like that, if you run a course for your newly diagnosed diabetics, which is accredited as being of a quality similar to, the kind of Desmond and Daphne type things. And QuizMet accreditation of your group clinic model will give you that quality standard. So if you get QuizMet accreditation, you can actually make sure that you get those 11 QOF points. And ELC is working with QuizMet and has created a sort of lean accreditation process for general practice, which you can potentially access via our training program. That means that you can get that QuizMet accreditation. So that would mean that your training would in effect kind of pay for itself in the first year by doing that. So that's another thing for you to be thinking about. Then, of course, think about local enhanced services that might be commissioned. For instance, in Devon last year, they did a big, the public health team paid GPs to do health checks. You can do group health checks. There will be other locally commissioned services around long-term conditions management, improvement, all that kind of thing. So that's another source of funding. Also think about inequalities, because you can use group clinics to deliver very specific interventions aimed at people with a particular from a particular ethnic group, for instance, or who don't speak English as their first language. And it's really easy to do that using the group clinic model. And then think about winter pressures. That always has money attached to it. Think about your Laura, just share with us quickly around the COPD winter MOTs you did and how you managed to use those to address winter pressures.
Yeah, as I said, it's a plan that we've tweaked over the years, but we realised we were doing COPD reviews in March, which is fine for QOF and not very good for patients. So we're trying really hard, and we've honed it each year. We're starting in July now and doing it as a pre-winter MOT. And trying to see all these people with COPD before the winter pressures really hit. Try and make sure they're set up, all the different QOF needs, but also all those other social things like singing and heating and using fans and scarves and all that other stuff that you might not get through in a one-to-one, back-to-back. And we are looking at some of our patients where this is one place where we thought we would try a specific group for our patients that are repeatedly using rescue packs, so we can really target about why we worry and spend a little bit more time talking around that if they're agreeable to that. Obviously, we always try and do our groups led by the patients, but you can offer and say, this is something that we'd like to talk about. Are you happy? So our patients needing lots of rescue packs, that's one of the places we're really looking at specifically now.
Yeah, so it's really thinking, isn't it, putting ourselves into the shoes of the patients and thinking about how we're going to use this model to help us. So, if the objection you're getting is this is, how do we make this pay? Loads of ideas there, hopefully, that will help you to think about how to do that. Next slide, please. So also think about things that can help with workforce development, because that's the other side of the coin in terms of funding. So, have you used up all your R's roles monies? Can you use some of those to give you, say, a care coordinator to help you to make this happen? Lots of people that we work with have got a fellowship funded for one of their staff members so that they can be the implementation lead and use their fellowship as a way of sort of supporting them to give them some headspace. So there's quite a few of you who talked about headspace. Think about fellowships. Could you use those? Contact your training hub and see what sort of support they can offer, and if they can't, then work with us on a business case to get access to funding for training. That may well be possible through your training hub or the workforce development team at your ICB when you say that it's something you want. And think about partners outside the NHS. So could you work, for instance, with a local diabetes support charity to run your group clinics? They could provide a facilitator, maybe. You can even look at building volunteers amongst your patients to take on that role. So there's loads of different ways that you can actually really creatively work to build your workforce's capability. Next slide. So I am aware of time, and I know that we're going to probably be running out. So I'm going to have to speed up a little bit on the next few. But we've also remembered that this is mentioned within modern general practice guidance. So when you're, PCNs do have also budgets available for delivering modern general practice. Get in touch with your PCN lead. Say, we want to do group clinics. How can we access some funding for training, and get them to look at what budgets have been made available, because it clearly is part of the delivery of modern general practice. Next slide. If you're working in secondary care, note, and I see that Megan has popped into the chat that she is looking at this. Group appointments are specifically mentioned within the collective care agenda. So again, there should be funding available to look at transformation and delivery of the elective care reform plans, and that's something that we can help you to tap into so that you have access to support. Next slide. I'm not going to go into this just now, but what I'm going to ask to Car Park is that we send out to the group the executive briefing that's been prepared on group clinics in the 10-year plan. If you could add that to the chat, please, Alicia, and just move me on so that we can talk about the next. Likewise, that's what I'm going to send you all out. There's a very comprehensive report that's been written by NHS England, and that will give you loads of insight. It'll also give you a lot of the evidence, and it also has a case study in it of Laura's practice. So a lot of what Laura has talked about today will be in that report too. Okay, so I want to spend a little bit of time talking about engaging skeptical colleagues. Guys, if you've got any questions, can you pop them into the chat, because I am going to sort of go through this pretty quickly. Engage. So there are a number of key steps. The first one is getting a senior clinician and a practice manager or manager within your kind of faculty or speciality behind you, because without those senior kind of sponsors, it's going to be really hard for you to get this going. So if you are struggling with that, think about using the evidence base. Think about talking about the potential benefits for QOF and all those kind of things in primary care. Think about the potential of impact on waiting lists if it's in secondary care settings. Really work to establish what matters to that individual, and then look at putting together a little kind of case for them that involves that evidence, that involves case studies. We can help you with that. There's also masses of resources on our website. Look at what local support could be available. Talk to your training hub. Talk to us, and also see if there's any local pioneers in your area who are also already doing something. And if one of your clinical leads or your practice manager knows that practice, maybe encourage them to have a bit of a natter about how it's going with their group clinics, because sometimes that can work just as well as the more black and white evidence. Next slide. So I'm sure that you've had experience of all of this, Laura. We're going to run through it very quickly, even though we're going a little bit into the Q&A time, because I just think it's so important. So we've got a nurse colleague who says, I can't provide personalised care in a group because, my patients are all very complex. They really need my one-to-one attention. Or maybe they're kind of worried about discussing intimate issues with patients. They think that they won't actually kind of, open up. What would you say to a nurse colleague who was saying that kind of thing?
I think we have to think all patients are complex in their own way. There are some things that might be intimate. So on our group board for diabetes, we've got a statement at the bottom talking about sexual dysfunction. And if it's a concern for you and that you want to talk about that separately, you can. Actually, patients will often bring it up in the group and they'll talk about it openly. But it does give them that say-so to say, look, in the one-to-one, you might decide you want to leave them to the end and talk to them just separately. Clinical knowledge is up to this. Well, I think that's something you have to think about yourself. I'm more than happy to say to a patient or group of patients, actually, I don't know the best answer to that, or I need a second opinion. And I think you have to be confident in that. But you should know your clinical knowledge really for one-to-one as well, because it's easier to hide in a one-to-one.
Yeah.
And complex conditions, you can often cover a few extra bits while you're there as well. I think it's picking the big wins first.
Yeah, absolutely. So with clinical leads, what they tend to talk about is the evidence. Often people worry about confidentiality. The thing you need to know is that, the confidentiality stuff is all covered. It's been all signed off by NHS England, and you learn about it when you do your training. I think that Alicia's already covered it in the chat, actually, in response to somebody's question. Be prepared to talk about how it impacts, how it's going to help you with your targets. We've got loads of case studies that can help you with that. So, these are the kind of things that your clinical lead might say. Next slide, please. Practice manager. I've heard it's a lot of extra admin. There won't be time savings for my team. How are we getting paid anything? So you've got a bit of a story around in those enhanced access and how you can get paid for delivering group clinics. Will it help deliver GMS? I think we've answered that one for you today as well. The admin stuff, it will take you a lot of time if you don't tap into resources that help you to reduce the time. Laura, you said it, didn't you, that you found having access to templates and stuff really helpful.
Yeah, we've tweaked our templates, but our admin team now, they can predict what we're going to say. As we're talking about something, they might be handing out a leaflet or putting a slide up on the screen. They know where we're going. We've worked together as a tag team for a long time. So it does take more time at the beginning, but once you get going, it saves a lot of time.
Absolutely. And and then don't forget your receptionists and your HCAs and your admin team. They're also part of the team, aren't they, Laura? How important is it to engage them and get them on board?
They're after your management team, they're the most important, because if you've got a reception team that don't buy into it, they'll be booking one-to-ones because they think it's better. Our HCA team actually book in the diabetic groups, and while patients are having their blood test or whatever else they're having, they'll be asking about them as well. So they're the ones that can have that one-to-one conversation while they're doing something else. So absolutely vital.
And in our route map that supports you to make the change, we've got a whole section on engaging the staff, and that is really, really important. We give you tools and resources to help you to run little briefings and little scripts for your admin team to use when they call people and all these things. So it's a lot of this stuff, the hard work has been done for you. Next slide, please. Okay, so making group clinics a priority. It's about, in primary care, this is about, delivering QOF, really. That's the bottom line of it. You've heard it from Laura. This is highly effective as a way of delivering QOF, but in a way that is much more engaging and supportive. So just get agreement from your team to start with one pathway, and that's where you're going to start. And then once you've proven the case and shown that it works in one pathway, you can think about moving on to others. If you're working in specialist services, we realise it's all about waiting times, and there are lots of ways you can use group clinics to help you to address waiting times. I've actually just written a little paper about this. It is specifically for women's health, but if you Alicia, if you put a message into the chat, I will actually create something which is a little bit more generic that we can send out for people who around secondary care. We'll just send it to the secondary care people who are on the call. Okay, next slide. We're nearly there. So creating the headspace for making this change. So as I said earlier on, if we are saying we haven't got time, it means it's not a priority for us. And the problem is that urgent things that are kind of like people have put high up our agenda, often take precedent over the things that actually would in the long term save us time and make what we do more impactful. So if you want to create headspace for this team, for this change, what you need to do is to make the group clinic model a priority for your practice. We've talked about this, using the evidence base, getting the leadership team on board, using tapping into funding. That now that you've heard about some of these things, you might think, I didn't think to even talk to my training hub about this. I'm going to go away and do that. Making sure that group clinics become a key kind of improvement project within your organization. Talking to your PCN. At the moment, we're finding that there are a lot of PCNs who do actually have access to funding to support making changes like this. So it is not impossible to get access to funding, and that is going to give you that headspace. So just persevere, keep in touch with us, and we will help you with that as well. Next slide. So we literally have got a couple of minutes for any questions. Maria, you've asked, are there set templates for group sessions? Yes, there are, and that's all part of the route map and the toolkit that we provide as part of our training. Has anyone else got any other questions? Alicia, you've been monitoring the chat. Is there anything you've picked up on that we haven't been able to answer yet?
So there was one question a little while ago from Rosie. How do you select patients to attend a group clinic? So that's sort of with reference to asthma group clinics and how to invite patients based on their birth month and knowing who's the most suitable for a group clinic.
Shall I go?
Yeah, please.
I would say rather than thinking about who's most suitable, is just think about who's not suitable. So people with learning difficulties, dementia, memory problems, maybe some people with severe mental health problems that might be a bit disruptive. So I'd look at those people first, exclude them, and actually just go for the next 10 people that need an annual review, rather than picking any, choosing at all. So when we did our first diabetic group, we excluded those special groups, and then it was just basically who are the next 10 people that need an annual review, let's book them in, and we went from there.
Yeah, absolutely. So Laura, you're just the perfect role model for this, because you've just said it exactly, the best practice. You don't include people, you have exclusion criteria. That's the key thing, isn't it? Because even whether you're poorly controlled, whether you're well controlled, you still benefit for being in this particular environment. So we've got another one. Do the doctors go into specific patients to add notes to the records? So tell us, how do you document, just quickly?
So I use a template. I will document the one-to-one decisions, so any prescribing decisions, next blood tests, anything that's specific that I want to do. But my facilitator will be taking notes throughout the whole group. And once I've filed the notes, they edit my notes and do a comment added by facilitator, and we'll put in a summary in everyone's notes of everything that's been discussed. So I don't have to do any of that.
Yeah, so it really can save you some time on documenting in the end, can't it? Because it's like you've got a little physician's associate sitting next to you,
They're brilliant.
sort of, doing all your right. And I've heard this as well with asthma, where doing asthma care plans, for instance. The one team who have completely scaled this up, they hardly do any one-to-one asthma reviews anymore. They do video group and face-to-face. And they saved as much nurse time by the nurses not having to write the care plans up as they did from doing the group clinic, if not more. So they got like a double whammy in terms of efficiency, which is amazing. Things like foot checks in diabetes, those in your practice, those get done anyway, don't they, in advance?
They're done with the blood pressure. In fact, diabetes is quite easy, and hypertension is a really easy one to do because you've got all the biometrics usually beforehand. But we will highlight, so anyone missing any QOF data like an ACR or an up-to-date blood pressure, I know in advance it's on the table. I know who we need to pick out, and the facilitator will do that. So it's all done in advance.
Yeah, so I'm just picking up. So, Holly, we'll talk about people with learning disabilities in a minute. Let's just do some of the processy ones. So, what would your be recommendations on who makes a good facilitator?
First of all, someone that's keen. So we started off with 2 of our patient services team that really wanted to just extend their role a little bit. And they do the admin and the facilitation. So they understand the processes to in advance and then what goes on in a group. So they've got both hats on. So to be honest, if anyone's keen on it, go with them right at the beginning. Don't work on your skeptics, go on your keen people and bring them along.
Yeah, and the other thing you can do is, Tess, is you can use it as a way of bringing staff on. So if you can potentially use trainees, people who are new to practice. You can get a less experienced nurse to buddy up with a specialist diabetes nurse so that she can see how she manages diabetes, so it can be a really good sort of skills accelerator, can't it? And
Yeah.
HCAs can, take on the role of the facilitator as well. So it really means a great opportunity to work that way. So thinking about learning disabilities, Holly, you're right. Some patients with learning disabilities could join a mainstream group with reasonable adjustments. But the other thing for you to think about is doing, for instance, health checks for people with learning disabilities in their own group, so they can come along with their carer. You probably make the groups smaller. They might even come with their key worker rather than the family carer, and they can actually, you can really meet their needs and do the group in a way that works for them. And that's the beauty of this model, because you can segment your patients, you can deal with them in a very different way, can't you? So, okay, we're pretty much at the end of the questions now. I'm going to hand back to Alicia, who's given